pause it. I think Dr. Gross is coming up.
Structure? Yeah, that's in the wrong part of structure.
How about yourself?
I think I'm meant to do night
You guys staying busy?
It's $1. I will talk them out of it.
Is that pointers working?
I'm doing volunteer work.
They're not volunteer work.
I know.
No.
This is emergency.
Yeah.
We're gonna have one.
Yeah, that's fine.
Actually,
Expecting people to
give
wander in and out.
me 5 minutes. Give me 1 second.
I just want to make sure. I know, I was excited to be there. Yeah, I know. I just was like, just making sure before we were Well, I think you're. That's when carrying it around. Very good.
All right, we're gonna start this morning. I want to thank Dr. Bauer for coming. He's been an outstanding colleague to work with. So he is the director of the EP lab here at SSM Heart Institute. He also shares his cell phone number, which I think is the best part. Just kidding.
And you folks took very good care of my
we
wife.
had the pleasure of
yeah.
taking care of it. And she spent a little time in the hospital, so we were able to even use the consults.
Got some very quick consults.
While he was in the house. He didn't have to come in from home. So
That's right.
Anyway, so a much needed lecture for us. People will trickle in.
Sure. No, thank you, Bill. And very much appreciate the invitation to join you all and talk about peripartum cardiomyopathy today. Also very much appreciate your wonderful care for my family while they were here. So I'm happy to help in any way that I can now or in the future. So just a little bit about me, first of all. So I'm a cardiac electrophysiologist. I treat primarily patients with heart rhythm disorders, and that also includes patients with heart failure who are at risk for ventricular arrhythmias in most instances. I did medical school at SLU, then did the first part of my training at the Mayo Clinic in Minnesota, and did cardiology and electrophysiology at the University of Oklahoma. So I've been back here in St. Louis at SSM for about the last 2.5 years. I have no disclosures. If anyone would like to clue me in on some, I'd be happy to look into those. In terms of the lecture today, I did want to talk a little bit about the epidemiology, risk factors, and prognosis for peripartum cardiomyopathy. Some of the underlying pathophysiology, which I think is important and is continuing to evolve. If I'd given this lecture 5 years ago, it would probably be very different than some of the stuff we're going to talk about today in terms of pathophysiology. And then also, talk about diagnosis, prognosis, and treatment of these patients, including some of the special considerations that are particular to your groups of patients. So, just in terms of kind of an overview and history of peripartum cardiomyopathy. The initial case descriptions date back to the late 1800s, where it was almost seen as a coincidence that patients developed heart failure shortly after giving birth. In the 1930s, it was essentially described as a unique clinical entity, a specific type of heart failure. But it wasn't really until the 1970s where the established diagnostic criteria were evaluated that we'll talk about here in just a minute. And also, even later than that, when we further refined those to include echocardiographic criteria for diagnosis. So this is a long-winded definition of peripartum cardiomyopathy. As I said, it's been evolving over the years. The key features are that it occurs in the peripartum period, so either towards the end of pregnancy or in the first few months after pregnancy. Some of the earlier definitions were rather strict in terms of that timing. I think that is a bit evolving as we understand more about the disease and understand that it can occur a little bit earlier in pregnancy than previously thought, and sometimes present even later after in the postpartum period. But again, the key features are it occurs in the peripartum period. It's an idiopathic cardiomyopathy. So in other words, we don't have any other potential causes for the cardiomyopathy. The patient doesn't have severe valvular disease. They don't have coronary artery disease. They don't have other things that are known to contribute to decreased LV function. And it's primarily due to left ventricular systolic dysfunction. So in other words, we'll see a left ventricular ejection fraction on echocardiogram or other assessments of LV function that are below the normal range. And just for reference, since you probably don't look at echoes quite as often as I do, although you certainly see them on the kids fairly often. For adults, normal ejection fraction is 55 to 65% in most institutions. So below 45% we would definitely consider abnormal, and there can be patients in the intermediate range which have progressive disease, and so those would be patients we would want to follow. And again, it occurs towards the end of pregnancy or in the months following delivery, and other reasons for heart failure have been excluded. Traditional timing is 1 month before or 5 months after delivery, but again, as I said, that's been expanded a bit. And also, to talk a little bit about the NYHA class. Again, this is something that we use to classify severity of symptoms. It's not a particularly helpful tool in terms of prognostic value because the same patient can be NYHA class 4, which means dyspnea at rest, and a week later can be NYHA class 1 or 2 on appropriate treatment. But it is a useful method of seeing their progress as the disease is being treated. So again, class 1, no symptoms. Class 2, mild symptoms, and typically with relatively vigorous exertion, they would get symptoms. Class 3, they'd get symptoms with minimal activity. In class 4, they have symptoms at rest. In terms of the epidemiology, the incidence varies considerably throughout the globe. So in the United States, the reported incidence has been anywhere from 1 in 2,500 to 1 in 4,000 pregnancies are associated with peripartum cardiomyopathy. In Haiti, that's up to 1 in 300, and in parts of Nigeria, that can be up to 1%. Okay, so there's significant geographic variation and significant variation amongst heterogeneous populations such as ours. Hispanic Americans generally have a lower incidence and has been reported in the literature, about 1 in 10,000 or so. And risk factors for developing the disease are African descent, and so that potentially explains some of the increased incidence in parts of Africa and Haiti. Preeclampsia and hypertension is certainly a very important risk factor for the disease. Multiple gestations. And there's some controversy with regard to multiparous women in that approximately a third of patients will develop the peripartum cardiomyopathy with their first pregnancy. So some studies have reported that multiparity is an increased risk factor for peripartum cardiomyopathy, but that remains a bit controversial. Also with advanced maternal age, same kind of a thing. There's conflicting data with regard to that. So in general, if we look at the breakdown of when peripartum cardiomyopathy is diagnosed, most commonly it's in the first month after delivery. So again, if time 0 is here for delivery, we have months postpartum to the right and weeks antepartum to the left. Again, the bars in green are when we would traditionally ascribe the strict time frame of the 1 month before and 5 months after. But there are reported cases, and in this case series, were a not insignificant number of cases that occurred even earlier in pregnancy. So something to bear in mind. In terms of prognosis, that too has changed, I think, significantly over time. In the first large case series from the early 70s, which was reported by Dr. Demakas, 27 women were included in the series. So again, this is a rare disease. Most of the case series are relatively small, and that does somewhat limit the interpretation of the data. But about half of them had persistent LV systolic dysfunction, and of those, the mortality rate was 85% at 5 years. Okay, so obviously not what we're shooting for. And of the patients who died, 3 of the 11 patients that died, their deaths occurred during a subsequent pregnancy. Okay. In those that had a recovered ejection fraction, so their ejection fraction was decreased and then returned to normal, there were no deaths in that group. A little bit later case series, 14 women showed a mortality rate overall of 43%, so somewhat improved in the intervening 15 years. And again, that could be partially due to advances in the treatment of heart failure overall. But again, one of the things that came out are higher ejection fraction at initial diagnosis, smaller LV cavity dimensions on echo were associated with improved prognosis and likelihood to completely recover the ejection fraction. And then more recently, in the modern era, the most recent case series that I included here, approximately 54% of the patients had recovered their ejection fraction by 6 months on optimal medical therapy, and we'll talk about exactly what that involves here in just a minute. The mortality rate of the studies that were included in this meta-analysis was anywhere between 0 to 18%. The largest case series, which was actually a retrospective review of all patients diagnosed with peripartum cardiomyopathy in the United States, had an in-hospital mortality rate of about 2.5%. Okay, so again, that's not long-term data. This is in-hospital mortality, but it does show that in general the trend is toward improving mortality in these patients. Okay. Also noted though were some incidents of continued high mortality and poor prognosis, and some of the markers that were associated with poor prognosis and decreased longevity were, again, African descent and lower socioeconomic status. Why that's the case, it's difficult to pin down exactly, but those were some things that did come out in the study. In terms of overall prognosis, obviously, and I think the data bear this out, patients whose ejection fraction and heart failure recover do better than patients whose ejection fraction remains low. And in terms of what you can expect for recovery, most of the patients whose heart failure is going to or whose ejection fraction is going to recover do so relatively quickly on medical therapy. So this is a graph showing months post-diagnosis and ejection fraction. So in green, we see the patients whose ejection fraction eventually recovered. In red, we see the patients whose ejection fraction remained depressed but did not require transplant. And in yellow, we see the patients who ultimately required heart transplant. And as you can see in green, the biggest jump in ejection fraction from a little over 20% to a little over 40% was seen even in the first 2 months of therapy, with continued improvement over time. Whereas the curves for patients who did not recover were much less steep. So again, it's important to check serial assessments of these patients because that does carry some prognostic value. Independent of symptoms, independent of other things, we want to see, is their ejection fraction recovering over time? And if it is, that's certainly a good prognostic sign. Now, just to make you feel a little bit better about patients with peripartum cardiomyopathy, overall their prognosis compared to patients with other forms of heart failure are actually pretty good. In the top here, we see patients with peripartum cardiomyopathy, and again, on average, mortality rate over prolonged periods of time, 5 to 10 years, is on the order of about 5 to 10%. Okay. Whereas other forms of cardiomyopathy, the idiopathic dilated cardiomyopathy, is closer to around 45%. Infiltrative cardiac disease, so amyloidosis and other things like that, is absolutely abysmal. And then ischemic heart disease is somewhere in the middle. Now, that being said, you're dealing with young women who have many, many decades ahead of them, as opposed to 80-year-old men who have had multiple MIs. So obviously, we want to be much more aggressive in treating your patients and making sure that we give them the optimal chance to recover and live a long, healthy life. Question that commonly comes up: what do we tell people about having another pregnancy? So I think that the data is relatively clear. If your ejection fraction has not recovered, so in other words, you've had peripartum cardiomyopathy, your ejection fraction is still depressed, then those patients should, in general, be discouraged from having another pregnancy because their chances of worsening heart failure and of mortality are significant. So again, these are the patients in green that we're talking about here that have ejection fractions that have not recovered and subsequently became pregnant. These are data out of USC with their case series of about, I want to say 70 patients or so. And again, significantly more likely than patients whose LV function have recovered in red to have worsening heart failure symptoms during pregnancy, to have a decrease in their ejection fraction of more than 20%. So both groups are likely to have a decrease in their ejection fraction, but obviously a decrease in the ejection fraction of 20% when you're starting at 30 is much more significant than a decrease in your ejection fraction of 20% when you're starting at 60. Okay. Also, more likely to have persistent LV dysfunction after the second pregnancy, but a not insignificant number of patients whose EF had recovered after their first pregnancy will show persistent LV dysfunction after their second pregnancy. So it seems to be a cumulative insult to the heart if they do develop peripartum cardiomyopathy a second time. Okay, and their EF is less likely to recover. The good news is that the mortality rate in this case series for patients whose EF had recovered was 0. So generally they'll get through the pregnancy, all right. They may have residual LV dysfunction, they may have worsening symptoms, but they don't typically die. Whereas patients with a persistently low ejection fraction who become pregnant again have a mortality rate that's quite significant, almost 20%. So, putting my basic science hat on, and I don't claim to be a basic scientist, so please take this with a grain of salt. There are multiple potential etiologies for peripartum cardiomyopathy, and those have been studied extensively over the last several decades. The most common traditional etiologies in pathophysiology include infection with cardiac enteroviruses, so we see Coxsackie virus sometimes cause a viral cardiomyopathy. It was thought potentially to play a role. Autoimmune conditions, including antibodies directed at cardiac myosin, and microchimerism from the fetus, prompting an autoimmune reaction, again, thought to play a role. Apoptosis and inflammation with interferon gamma and elevated C-reactive protein. So in general, these patients, and we'll get into some of the additional data here in a second, in general, these patients do have a pro-inflammatory state that you don't typically see in other forms of cardiomyopathy and don't typically see in healthy pregnant women. Okay. And then the two newest kids on the block that I think have the most promise in terms of future treatments for peripartum cardiomyopathy are increasing oxidative stress and its effects on prolactin metabolism, and disordered angiogenesis and their association with preeclampsia. And we'll talk again a little bit more about those in just a second. So again, getting back to the viral hypothesis, it was found in early series when they were doing endomyocardial biopsies on these patients that viral genetic material was found in up to about 30% of patients. It's hard to know what to make of that. It's not a causal relationship. Okay, it was potentially incidental finding, and since we don't do endomyocardial biopsies on healthy people, it's hard to know whether or not there are an equal number of patients that we'd find it on without heart disease. Again, fetal microchimerism and invasion of fetal cells into the circulation, potentially prompting an immune response on the part of the mother that causes or contributes to heart failure has been postulated. I have not seen terribly compelling data that is a likely cause of the condition. And then, as I said previously, we do see an increased inflammatory reaction in most of these patients. So TNF-alpha, interleukin-6, which is responsible for flu-like symptoms in many people, interferon gamma and CRP are all significantly elevated compared to both controlled patients with idiopathic cardiomyopathy in pregnancy and healthy pregnant patients. So there's clearly a inflammatory response as part of this condition. Whether it's a causal cause and effect relationship is difficult to say. And contributing to this, again, on these same biopsy specimens that we find viral material, we frequently find other evidence of inflammation and fibrosis in these patients. But again, the causal linkage there is somewhat lacking. And again, the more recent data that suggests a more basic cellular mechanism for this condition really comes in two parts. The first is an increase in oxidative stress that can occur in these patients, and there are a variety of markers that have been shown to be correlated with increased oxidative stress in these patients, including oxidized LDL and other things. That increased oxidative stress can alter the function of a variety of enzymes, including, most importantly, enzymes involved in the proteolysis of prolactin. And one of the enzyme byproducts of prolactin, the 16 kilodalton molecule, is extremely cardiotoxic. So it's pro-apoptotic, anti-angiogenic, vasoconstrictive, and these can, in both human and animal studies, form what essentially looks like peripartum cardiomyopathy in knockout mice. The good news is, and a point of ongoing research, is these effects can be reversed by suppressing prolactin with bromocriptine. Again, not quite ready for prime time, and we'll talk about this in a minute, but a promising area of research. Disordered angiogenesis is another big potential factor for development of peripartum cardiomyopathy. So VEGF, vascular endothelial growth factor, is normally increased in the heart in response to pregnancy and in late pregnancy. And that's due in part to some of the normal anti-VEGF factors that are produced in the placenta in late pregnancy. And so it's meant as a cardioprotective response. However, in patients with peripartum cardiomyopathy, that protective response is blunted. And the anti-angiogenic factors that are produced in the placenta can also have some effects on the heart. These effects can be partially reversed, and I neglected to include on the slide, in mice. So can be partially reversed with exogenous VEGF. There's no clinical formulation available for use at this time. In fact, we have a number of anti-VEGF drugs that we use in oncology, that one of the side effects, not coincidentally, is cardiomyopathy. Okay, so again, a plausible biologic linkage. And again, this may be partially responsible for some of the association between peripartum cardiomyopathy and preeclampsia, both having to do with disordered angiogenesis. So in terms of kind of a global picture of the pathophysiology, normally in pregnancy, again, there's some hypertrophy of the left ventricle. That's a normal response to pregnancy. And in most patients, in late pregnancy, there are protective signaling pathways that increase the production of VEGF and maintain normal cardiac function during pregnancy. In patients with peripartum cardiomyopathy, those protective signaling pathways are interrupted. And again, it's probably a multifactorial interruption, so it's probably not just one thing. And those patients subsequently go on to develop peripartum cardiomyopathy. In about half of patients, that process reverses itself with medical therapy, and those patients recover. But in a significant percentage, their ejection fraction remains depressed, and they have irreversible scarring, fibrosis, and LV dysfunction. So, in terms of diagnosis, the things we typically look for in patients with heart failure, so dyspnea on exertion, orthopnea, or shortness of breath lying flat, paroxysmal nocturnal dyspnea, suddenly awakening short of breath at night. I'm guessing you see a lot of patients with those symptoms. So, one of the things that again, is really key is your knowledge of what's normal in pregnancy, and pointing out those things that may not be normal. Because one of the things that also comes out in the data is that patients in whom the diagnosis is delayed tend to do worse than patients who are diagnosed early in the course of the disease. And so having a high degree of suspicion for particularly people that have multiple risk factors, preeclamptic women, African American descent, multiple gestations, etc. Those are things that you want to have a higher degree of suspicion when those patients come in and are complaining of shortness of breath and edema than you would in patients who are otherwise don't have any risk factors. And again, same thing, same signs on exam: RALS, lower extremity edema, S3, particularly in the postpartum state. It is abnormal, obviously. In pregnancy, the majority of your patients will have a third heart sound. So, and because the diagnosis is difficult to make on clinical grounds in pregnant women, it's certainly useful to have ancillary testing. I think you're all familiar with the brain natriuretic peptide and its association with acute heart failure. Again, other forms of or other etiologies of shortness of breath, including pulmonary embolism, can cause mild elevation in BNP, typically don't cause the significant elevations that we see in acute decompensated heart failure, where the BNP levels are 7, 8, 900. Okay. Pulmonary vascular congestion is almost uniformly seen on chest X-ray in advanced stages, but in early stages it may not be. Okay. And one thing again that didn't put in under the signs would be elevated jugular venous pulse. So if their JVP is up to the top of their ear, that's abnormal. Okay. And again, EKGs, we would routinely get EKGs on most of these patients. In most cases, they're non-specifically abnormal. They're usually not normal. Okay, they're usually not completely normal, but they usually have relatively non-specific findings. So abnormalities in T waves, abnormalities in QRS width, things like that, which don't confirm a diagnosis, but raise your degree of suspicion that there might be something else going on. And then obviously the definitive diagnosis for LV dysfunction is typically made with echocardiography. So having a low threshold, again, in patients with multiple risk factors who come in short of breath for getting an echo, because that will certainly change management. in terms of treatment, and please stop me anywhere along here if there are questions. In terms of medical therapy for heart failure, so typically we have a multi-pronged approach to the treatment of heart failure, including drugs that reduce preload, drugs that reduce afterload, and drugs that inhibit some of the abnormal signaling that goes on during heart failure, which over long terms can be pathophysiologic. So during pregnancy, hydralazine is a reasonable choice to decrease afterload. Nitrates would be kind of plus minus, I think, during pregnancy, but certainly can be used after pregnancy to reduce preload. Spironolactone, so aldosterone antagonists, in addition to augmenting diuresis in these patients, have also been shown to beneficially affect remodeling of the left ventricle. So over and above the diuretic effects, you get some added benefit from spironolactone. And then in terms of beta blocker therapy, so these patients chronically should be on beta blocker therapy. As we'll talk about in a minute, it's not something you want to start when they're acutely decompensated, okay, because that's going to potentially worsen their cardiac output acutely. And it's also very important that we pick the right beta blocker, because there are really only 3 beta blockers that have been shown to improve mortality in patients with heart failure. And those are carvedilol, or Coreg, metoprolol succinate, or Toprol XL, not the immediate release form of metoprolol that we typically use, and bisoprolol. So really, those are the only 3 beta blockers that have been shown to improve mortality in heart failure. And again, ACE inhibitors and angiotensin receptor blockers are mainstays of traditional heart failure therapy. We can't use them while they're pregnant. There are too many damaging effects on the fetus. But obviously, as soon as they're postpartum, it's reasonable to start them on ACE inhibitor and ARB therapy right away. Obviously, things you need to watch out for any of these drugs, particularly the aldosterone antagonists and the ACE and ARB, are electrolyte fluctuations and fluctuations in renal function. So that's something that, again, as the patients are acutely decompensated, we'll want to monitor very, very carefully in the hospital. So other things, and again, all of these drugs have been shown to improve mortality. Okay. These drugs have not, but they are drugs that we use as temporizing measures to try and improve symptoms and get patients to a point where they'll tolerate some of these other medications. So inotropic drugs that improve contractility, dobutamine and milrinone are the ones that we typically use. Will have some effects on lowering the blood pressure, particularly dobutamine, from vasodilation. So in patients whose blood pressure is okay, that's actually not a bad thing because it helps reduce preload. Okay. In patients whose blood pressure is tenuous to begin with, dobutamine might not be the best choice. Okay. Milrinone might have a little bit less of an effect on the blood pressure. And as we'll talk about in a minute, these patients have significant risk for thromboembolism, both venous thromboembolism and arterial and systemic thromboembolism. So in general, the recommendation is for patients with reduced ejection fraction and peripartum cardiomyopathy, in addition to the standard medical therapy for heart failure, to be anticoagulated. And that risk for thromboembolism seems to be over and above what you would normally expect in the pregnant women, and not typically explained by other risk factors. So it is in and of itself a risk factor for thromboembolism and generally an indication for anticoagulation. Okay. Digoxin and diuretics, again, are used primarily for symptomatic relief. So these patients, these don't improve mortality, and they're used to help improve symptoms for the most part. So other interventions, obviously if the patient's hypoxic, we need to fix that. And that can be something as simple as nasal cannula or something as involved as mechanical ventilation. And that's, again, going to depend on how the patient presents. In most non-pregnant patients, we can typically get by with non-invasive positive pressure ventilation as a temporizing measure until we can get their volume status corrected. Again, depending on the excursion of the lungs and other things like that, that may or may not be possible in your patients. Okay. In terms of cardiovascular support directly, there are some data on intra-aortic balloon pumps and improving cardiac output. I think there are not yet data in the literature on percutaneous left ventricular assist devices, but those are available here and can be used if needed to support patients. They offer a higher degree of hemodynamic support for the patients than a balloon pump typically would. This is a device called the Impella is what we use here, which essentially provides about 2.5 liters of cardiac output through a rotor mechanism. Now it's put in the left ventricle by a catheter, so in patients who have a left ventricular thrombus, it would be contraindicated. Okay, but that is something that's available. And then obviously if the patient requires higher degrees of support, they would probably need to be transferred for consideration of a surgical left ventricular assist device or heart transplantation. And roughly, again, reviewing the literature of the patients that don't recover their ejection fraction, 5 to 10% of them may eventually require cardiac transplantation. And those patients, if we can do everything we can to avoid that, that's preferable, because even though generally speaking outcomes with cardiac transplantation are pretty good, the degree of rejection, because again this is a potentially immune-mediated event, the degree of rejection is actually higher in patients with pericardial cardiomyopathy than it is with other forms of heart disease. Yeah.
Is the risk of VTE more directed towards central cardiac and pulmonary, or is it overall general risk?
The primary descriptions have been either LV thrombus or central pulmonary emboli, significant pulmonary emboli. But it's a systemic disorder, so typically if you have a central PE, it came from somewhere else. And I think that's probably true in these cases as well. But
does the recommendation want the therapeutic?
Yeah, so in patients, particularly with a reduced ejection fraction, and again, this is because of the increased incidence of left ventricular mural thrombi, it'd be a recommendation for systemic therapeutic anticoagulation.
So if it's just symptoms, you just wait and watch. How hard is it to look at LV changes in pregnancy?
It's typically we get pretty good pictures in most pregnant women. So in patients that you're suspicious of, say for instance they have the classic symptoms, you get an EF and it's in the 45 to 50 range, so it's not normal, but it's not severely reduced at this point. That'd be someone that you wouldn't necessarily start on anticoagulation, but you may consider starting on medical therapy for heart failure, and you would certainly want to follow their ejection fraction over time.
Wouldn't it be prudent though to at least use prophylaxis doses in anybody who has this condition, given the fact that they're immobilized and given these two risk factors?
Yeah.
Ladies aren't getting up walking around and.
Yeah, no, I think that would certainly be reasonable. I think that would certainly be reasonable. There aren't hard data on that. It's not been studied to my knowledge in terms of this condition in particular. But I think given their increased risk of thromboembolism generally and the factors associated with being in the hospital, not getting up and around, it would certainly be reasonable. Yeah. And again, this kind of goes over what we were just talking about. So increased risk of both venous and systemic emboli. So also things you want to keep an eye out for are patients who suddenly develop pain in their legs, or pain in their arms or in their abdomen for no apparent reason. CNS manifestations. So some of these patients will present with stroke from LV thrombus. And so those are all things that should raise your suspicion in patients who don't have a established diagnosis of peripartum cardiomyopathy. And in patients who do, should definitely pull the trigger for anticoagulation. And then one of the things that I'm particularly passionate about, since this is what I do for a living, is these patients have a high risk for ventricular arrhythmias. So any patient with a reduced ejection fraction, less than 35%, has an increased risk of sudden cardiac death. Okay, and in these patients, because we know their prognosis overall is good and significant number of patients will recover, that's something that we don't typically implant a permanent defibrillator up front. Okay, the only FDA-approved device to protect those patients in the interim is a wearable defibrillator made by Zoll. Okay, so while it would be nice certainly to have other options, at this point in time, those are the only devices that are approved for the interim period while we see whether the ejection fraction is going to recover. And again, I don't get paid by Zoll, but I do prescribe a lot of LifeVest because I think it's something that the worst thing that could happen is to have a patient, particularly in your population, who survives being hospitalized for heart failure, who's got a new baby at home, and then has a cardiac arrest at home. Okay, and the risk for that is not zero. But it's definitely real, and if it happens, it's not a good thing.
How well do they work in, our patients tend to be higher BMI, and
Sure.
they have large breasts.
Right, and those are definitely considerations that make it more challenging. Certainly I've prescribed them in patients who are morbidly obese. My patients also tend to be rather large, and so they do have devices that will fit them. Basically what happens is the rep comes to the hospital and fits the patient with the device, shows them how to use it. In terms of the actual layout of the device, it's essentially kind of straps, suspender-like straps in the front with a panel in the back that actually has the defibrillation electrodes on the back. And
So the jolt gets delivered from the back.
yeah. So the shock is from posteriorly, and so there are electrodes kind of at right about the level of the diaphragm that assess the rhythm. So they're typically under the breast. Yeah. So that being said, it would complicate things in terms of breastfeeding and other things like that, which, again, given the pathophysiology of peripartum cardiomyopathy, we may not want to encourage anyway. And we'll get to that in just a minute. The other big issue with these devices are insurance coverage. And so typically the good news is Medicaid and most private insurance companies will pay for them. It takes a little bit of paperwork, but in most cases they do pay for them. And again, I know this has been somewhat of an area of controversy, particularly amongst cardiologists. There are some who don't believe in these devices. There are some of us who do. I can tell you as a point of fact, in the 2 years that I've been here, I've had 5 patients that have had appropriate shocks for ventricular fibrillation from the devices and that saved their lives. Again, that's anecdotal. There are ongoing clinical trials with the device, but again, it's the only FDA-approved device for this indication.
In terms of insurance coverages too, in my understanding, you have to have a documented LV ejection fraction less than 30% for a certain period of time, like 6 months before you even qualify for it?
So you have to have a documented LV dysfunction less than 35% for 3 months to qualify for an ICD.
Okay.
So for a permanent implantable device. These devices, the external devices, are typically covered during that waiting period. So from the time of diagnosis until you would qualify for a permanent device is when you would wear this device. And the hope is, again, with most of your patients, that their ejection fraction would recover in that time and they wouldn't need anything at all. In the event that the ejection fraction doesn't recover, we would treat them the same way as they do with any other form of non-ischemic cardiomyopathy, and typically recommend implantation of a permanent defibrillator for prevention of sudden death at around the 3 to 6 month mark, again, depending on whether their EF is improving. So typically what I'll do, we get an assessment of their ejection fraction at diagnosis. Say their ejection fraction is 10% when they're diagnosed. If their ejection fraction has gotten up to 30% at the 3 month mark, even though that's still below 35% and is still puts them at risk for ventricular arrhythmias, it's a significant improvement. And so typically in those patients, I would wait a longer period of time to see whether their ejection fraction continues to improve, in which case they wouldn't need an implantable defibrillator. And if things stall out at 30% or so, then typically in the 6 to 9 month period, we would consider implantation of a defibrillator. Any other questions as far as this stuff goes?
In terms of somebody who, so you're on the ward and you have a suspicion, assuming that they're ready to be intubated, what's the first things that you would do in terms of stabilizing these patients? You mentioned the hydraulics and what have you, said that that's more for later on.
Yeah.
What do you do for the here and the now?
So in terms of the, if the patient is hypoxic and in respiratory failure, then obviously that's the first thing that needs to be addressed. And some form of positive pressure ventilation is going to be the most expedient way to address that. Now, if we can get by without intubating them and using CPAP or BiPAP non-invasively, then that would be preferable. But obviously, if they need to be intubated, they need to be intubated. And then after you stabilize their respiratory status, the next thing you really want to assess is their overall hemodynamics, and we'll kind of get into some of this here soon. But the blood pressure and the heart rate are typically going to be what drive what you do next. So if their blood pressure is okay and they're hypoxic, then typically you would want to try and get volume off and diurese them. Okay. If their blood pressure is low, then you're going to need to do something to support their blood pressure, and typically that's going to involve putting them on a 9-inch of some kind. So typically milrinone if their blood pressure's on the low side, and that'll allow you to get the cardiac output up enough so that you can then diurese. Okay. Does that answer your question? And Gil, did you have a question?
Yeah, I was wondering, at what point does transplant come into play?
Yeah, so excellent question, and certainly we're gonna get to that. That's a very good question. But so typically, if you've got a patient who's either hemodynamically unstable and you cannot stabilize them either medically or with minimally invasive interventions like the balloon pump or the percutaneous LVAD, then those would be patients that you would think about sending for typically a destination LVAD first in these patients, and then subsequently, if their EF doesn't recover, transplant. So most patients, from talking with the guys at Barnes and other transplant centers, most patients would typically have an LVAD, a surgical LVAD first. And these are devices, again, that are surgically implanted pumps with essentially a whole cord out of your left ventricle that has a pump in the abdomen that essentially can replace your entire cardiac output. So these people can be in ventricular fibrillation and still be up walking around. They're really quite impressive. Yeah.
Are you going to talk about the role of delivery in recovery?
So a little bit.
Okay.
Yeah, but no, go ahead if you.
Oh no, I was going to ask you to speak to that.
Yeah, no, and I've got kind of there was a reasonably good chart that helps talk about that a little bit. In terms of other adjunctive therapy before hopefully going to transplant or surgical LVAD. Again, there are some data on use of bromocriptine to suppress prolactin in its potential roles. These trials have been very small, 20 patients. Okay, it was a randomized trial, and in peripartum cardiomyopathy, 20 patients is not a bad number, but it does potentially suppress the cardiotoxic effects of the prolactin metabolites, and did show a significant benefit in terms of improving both mortality and ejection fraction recovery in patients who received it compared to standard therapy. So the downside of it, again, it's got some potential effects in terms of hypercoagulable effects. In general, these patients are going to be anticoagulated anyway, and it doesn't seem, at least in the small studies that have been done, that there's a significant increase in the prothrombotic effects related to bromocriptine as long as you're on anticoagulation anyway. Also, one of the TNF-alpha inhibitors that we use for claudication, amongst other things, has also been studied a little bit less rigorously in terms of its effect, but it did also, pentoxifylline or Trental, did also have some association with improved ejection fraction and improved outcome. But again, this was a non-randomized study, so it's hard to draw definitive conclusions from.
Bromocriptine, so it sounds like potential benefit, relatively low risk.
I would agree with that assessment, yeah.
So are there ongoing trials right now?
There are ongoing trials, not in the U.S. So most of the work on bromocriptine has been done either in Europe or in Africa, where their population of patients is higher. But the group that did the initial pilot study, which is kind of what I'm reporting in the 20 patient study, has an ongoing larger trial to more definitively evaluate the safety and efficacy of bromocriptine going on now.
So is this something that we should consider using in terms of this relative safety?
Yeah, so I think it would be a very reasonable thing to consider. Again, the way I look at it, and this might be slightly different than the way you look at it, the risks of surgical LVAD or cardiac transplantation are inordinately higher than the risks associated with the medication. So even though there may be some small risk of increased thromboembolic events, and most of those were seen in patients who it was given for suppression of lactation in other settings. So and again, their case reports, it's not been something that has been definitively shown in the literature to be an increased risk. So in these patients where the risk is relatively low, the benefit is potentially high in terms of saving their life, or at least saving them from significant morbidity related to progressive heart failure. It's certainly a reasonable thing to consider, in my opinion. Again, it's hard for me as a cardiologist to, when I'm used to dealing with heart failure trials that have 10,000 patients, to put much weight on a study that has 20 patients, but the effect was there. So, that's about all I can say.
Immunosuppression, you talk about pentoxifylline, but what about the steroids in it? Are there immunosuppressive
Yeah, so steroids, IVIG, have been tried. The results have been mixed. So I will say that those treatments have been, I would say, in vogue for periods of time, but it doesn't really seem to be as robust in effect over the long term. And the kind of durable effect on ejection fraction and improved mortality is lacking in those patients. We do sometimes use it in patients with a primary myocarditis, and certainly there are probably a subgroup of patients with peripartum cardiomyopathy that myocardial inflammation and plays a big role. But I think the real question in my mind, and that's yet to be answered, is definitively what starts the ball rolling. So what gets the cascade of all of the cytokines, all of the oxidative stress and everything else going. And I think that's not yet been definitively determined, and until it is, I don't know that we'll have a great answer in terms of targeted specific therapy for peripartum cardiomyopathy. I think the closest that we've got at this point is probably the prolactin hypothesis and bromocriptine. But again, I think that's still something that is going to need significant research before we can apply it to everyone. And there's also, again, some additional data. Yeah.
And for bromocriptine, there's a time we did bromocriptine that every single woman was not breastfeeding.
Yeah.
And those patients were not getting anticoagulated.
Right.
And that was every single patient.
And they also weren't coming into the cath lab with an MI 2 weeks later either.
Right. And back then, I think it was breastfeeding rates. Breastfeeding rates.
They're getting strokes, and that's why we stopped using it.
Right.
Yeah.
Yeah.
I agree, I mean, it's not like something you still have.
Yeah.
Right.
They weren't getting pericardium cardiomyopathy.
By now. And then breastfeeding rates back then was probably not as high.
Yeah.
We were
No.
doing all of it. I mean, it was part of the standard order.
To combine with some kind of anticoagulation.
Yeah, no, and I think that again would be the general recommendation anyway, regardless of whether you would use bromocriptine or not, because there is a significant increased risk for thromboembolism. Certainly, if you're going to be using it, then therapeutic anticoagulation would be in order.
We reviewed that study before, and it had some problems with it, even though it did show a big difference.
Right.
And one of the problems had identical numbers in both groups, so the randomized trial usually don't get the same numbers.
Right.
At 10 and 10.
Yeah.
So.
Yeah, and I'm not sure whether they just stopped enrollment at that point or yeah. Yeah, but no, and I think, again, this is certainly something that needs to be studied more rigorously before, we can definitively incorporate it as first-line therapy. But I think in terms of in patients who are not improving on standard therapy, before you would go to invasive therapy like surgical LVAD, transplant, etc., then I think that's a reasonable place to consider using it.
If I'm not correct, bromocriptine has to be given fairly quickly.
So in the studies, it has been, but it's also been shown, and one of the things I was alluding to earlier, it's also been shown to have a somewhat protective effect in patients who have a history of peripartum cardiomyopathy who then become pregnant again. So that's another potential role for it. But yeah, it's something that again, you want to, it's a fine line between waiting too long and giving it to everybody. So you want to get there before there's irreversible fibrosis, because at that point there's not going to be any medical therapy that's going to work. But at the same time, if there are concerns about either the evidence or the side effects, then you may not want to give it to absolutely everyone, particularly when the recovery is reasonably good in most patients. All right. So getting back to your earlier question about how do we manage this on a day-to-day basis. So step number one is stabilize the patient's vitals and hemodynamics. Okay. And again, this is typically going to come from what's their SpO2, what's their blood pressure, what's their heart rate, and are they perfusing? So the key question in managing heart failure is perfusion. So if they're peeing, if they're mentating well, if their renal function is okay, all of those kinds of things suggest adequate perfusion. If those things are missing, then we need to do something about it. Okay, and typically that's going to be dependent, as I said, on blood pressure, because if we have blood pressure to work with, there are a lot more options that we have in terms of medical therapy to help improve overall cardiac output. If the blood pressure is very low, then we need to get that up again as step number 2 after oxygenation, before we can work on some of the other things. So There's typically not a role for invasive cardiac monitoring of these patients with a pulmonary arterial catheter. And again, in the setting of increased prothrombotic risk, that's probably not something that we would want to put in anyway. Not infrequently would patients with severe decompensated heart failure require temporary inotrope support or even balloon pump or percutaneous LVAD. Again, these things are designed to be temporary and used regularly, and over the long term have actually been shown to increase mortality in most patients rather than decrease it. So these are things that we like to use for a shorter period of time as possible until we can get them on the drugs that have been shown to improve mortality. Okay. So step number 2 is typically try to get them euvolemic. So typically these patients will come in significantly volume overloaded, both from their recent pregnancy, but compounded by the fact that they're in acute decompensated heart failure. So they may have, 20 or 30 kilos of extra fluid on them in some cases. Okay. And generally speaking, as the blood pressure tolerates and as the renal function tolerates, we want to gently diurese them. Now, they may put out massive amounts of fluid in the first few days, but we want to stay on top of their electrolytes. We want to stay on top of their renal function to make sure that we don't get too much off too quickly. And then as we're diuresing them, again, diuretics are preload reduction in and of themselves. And as we're diuresing them, we want to put them on drugs to alter preload and afterload. So if we reduce afterload, the heart has to work less hard, essentially, is the bottom line. So the way I typically describe it to patients is afterload or blood pressure is what your heart's having to push against with each beat. So if we can reduce that and still maintain perfusion to the central nervous system, the kidneys, and everything else, then that'll promote cardiovascular recovery over time. That's not me. So typically we want to reduce preload and afterload as much as tolerated by their blood pressure. And again, as I alluded to earlier, you want to avoid beta blockers in the acute decompensated phase. So this again is going to potentially reduce cardiac output if given acutely. Okay, so we want to wait until they're relatively euvolemic before starting beta blockers. So one of the mistakes I commonly see, particularly internal medicine residents make, not to beat up on them too much, is they have somebody come in with acute decompensated heart failure. They're in sinus tachycardia rate of 120. They give beta blockers, and it makes their heart failure worse. Okay, it may help their heart rate, but it's going to reduce their cardiac output, going to worsen their pulmonary edema. So you want to wait until these patients are close to euvolemic before you start beta blockers. Okay.
In terms of the inotropes, you showed short-term inotropes.
Yeah.
What's the downside to using it long-term?
So downsides, excellent question. So downsides are ventricular arrhythmias. So most of the increased risk with inotropes, both milrinone and dobutamine, are an increased risk of ventricular arrhythmias, including VT storm and refractory arrhythmias. But then overall, it's been shown that again, this is in a general heart failure population, not necessarily specific to pericardial cardiomyopathy, but patients who require longer-term inotropes typically have a much worse overall prognosis.
And how does digoxin compare to?
So digoxin doesn't typically have a increased risk of ventricular arrhythmia except in toxic levels. So if you have if you're dig toxic, then there is an increased risk of biventricular VT and atrial arrhythmias as well. But in therapeutic ranges, it is reasonable, but you don't typically get the kind of increase in cardiac output with digoxin as you would with true inotropes. And then step number 3 in terms of treatment are to gradually start those medications that have been shown to improve mortality and promote recovery. And again, those are ACEs and ARBs or hydralazine and nitrates in the antepartum period. Typically would start them on very low doses of these medications. So for example, 2.5 milligrams of lisinopril once a day, whereas the standard dose for hypertension might be 20 milligrams. And again, we see these patients back frequently and increase the doses regularly, but it's something you would start very gingerly. Same thing with spironolactone. Typically, the doses that we see in cirrhotic patients that the GI doctors give for 100 milligrams a day or more, we typically start at about 12.5. Carvedilol 3.125 twice a day to start. These patients can be tipped over the edge very easily. And so that's why we start things very low and gradually get it up. And then again, we want to prevent the life-threatening complications that are associated with the disease, including ventricular arrhythmias and thromboembolism. Okay. And just getting back to your question a little bit earlier, Dr. Scheiken, in terms of an overall treatment plan for patients with acute decompensated peripartum cardiomyopathy, if they're hemodynamically unstable and in cardiogenic shock, then as we were talking about earlier, the first priority is to maintain oxygenation. And if they're antepartum and they're reasonably stable after maintaining oxygenation, then we want to start them on medical therapy for their heart failure. If they continue to be unstable, and we feel working together that there's time to either you check and see that there's fetal lung maturity or the patient's already been given steroids and you're comfortable with that, then at that point, an expedited cesarean delivery would be reasonable. Okay. And then we would go to the postpartum treatment. In terms of mechanisms of delivery and things like that, certainly in these patients, if you don't feel it's necessary from an obstetric point of view to do a cesarean section, then a facilitated second stage would certainly be very reasonable in these patients. If you think that they would be okay laboring. And again, that's something that we would certainly in most cases defer to your expertise on this mechanism of delivery. There's not been robust clinical data in terms of saying one method of delivery is superior to another in these patients. And then again, once we get them on optimized medical therapy, okay, if they're continuing to progress, if they're either not able to be stabilized, that's when we would potentially consider bromocriptine. Okay. If they respond to that, great. If not, then we're running down the road of the surgical LVAD or heart transplantation. Does that make sense? Okay. So, it's a rare disease, thankfully, but potentially has devastating consequences for young women and their families. Pathophysiology is still a little bit up in the air, but we're getting more information. And treatment with optimal medical therapy devices to prevent ventricular arrhythmias and anticoagulation are standard care for heart failure. And then the role for novel agents is I'd say, less well studied. So, thank you very much. Sure.
Can you educate us a little bit on sort of the natural progression of EMP? I mean, does it just stay up during acute, or does it stay up during the entire time of failure?
Good question. So it tracks very closely with intravascular volume. So as intravascular volume and LV stretch, in acute decompensated heart failure increase, it will go up. And as you treat the increasing intravascular volume, the LV stretch goes down and the circulating hormone decreases. So typically, if we check a level, at the beginning of a heart failure hospitalization and it's 1,000, we can check it again at the end of the heart failure hospitalization, and it may not be completely back to normal, but it should certainly be less. So typically 50% less or more.
So I don't know if you can speak to this or not, but in the evolution of our understanding of pericardial cardiomyopathy, I remember a time when dilation was necessary as part of the diagnosis and no longer is.
Correct.
Can you speak to that at all?
Yeah. So when we measure the LV function, there are a variety of measurements we can make echocardiographically, as I'm sure you know. And there are certainly well-recognized cases of patients who have decreased systolic function without dilation. So dilation tends to be a later effect. Okay, so typically you'll get decreased systolic performance first. So first you get decreased diastolic compliance. It is essentially the first manifestation that you can see in these patients even before systolic function declines. And then systolic function will decline. And only after systolic function has been down for some time and the patient's not been treated will you see dilation. So it's a later effect of the disease progression. And I think probably one of the reasons that was removed as a requirement was because you want to catch these patients and treat them early.
So it really doesn't have anything to do with differentiating people who have a hypertensive cardiomyopathy from people who have a pericardial cardiomyopathy.
Right. So typically, if for instance they had an undiagnosed idiopathic cardiomyopathy, either from hypertension or something else coming into pregnancy, so the things that can differentiate that would be typically the patients with idiopathic cardiomyopathies will present earlier in pregnancy. So typically in second trimester or so, when the volume shifts are the greatest, is typically when you'll see their exacerbations. Whereas pericardial cardiomyopathy tends to occur later in pregnancy. But in terms of differentiating one form of cardiomyopathy for another just on the basis of dilation, it's typically not very specific. So dilation is kind of the end stage of any type of cardiomyopathy, whether it's an idiopathic dilated cardiomyopathy, whether it's an ischemic cardiomyopathy or pericardial cardiomyopathy. Now, that being said, patients with pericardial cardiomyopathy are probably, again, if you catch them early, slightly less likely to have LV dilation than other forms of cardiomyopathy. But that's primarily because of the stage of the disease you're catching them in.
Question on family members. Say somebody who's got a family member who's had cardiomyopathy, assuming there's a genetic component to this, would you screen them during pregnancy? And if you did screen them, how frequently would you screen them?
Yeah, so it's a very reasonable question, and there are again case reports of familial pericardial cardiomyopathy, so sisters that have had pericardial cardiomyopathy, but I think more likely what you're speaking to is probably a family history of an idiopathic cardiomyopathy that affects other relatives. And I think certainly it would be reasonable in cases with a strong family history if you have more than one family member, or if you have an immediate family member who's had a defibrillator or heart transplant or something like that, to at least get an initial assessment.
EKG or an echo?
No, I'd probably get an echocardiogram if you're screening for cardiomyopathy. And again, if that's completely normal and the patient has no other symptoms during pregnancy, then it wouldn't necessarily be required to continue screening them during pregnancy. If they do, I would have potentially a higher degree of suspicion or lower threshold for doing it if they had a change in their clinical status, but I wouldn't do it just as a matter of routine.
The role for aspirin at all in any of these cardiomyopathies?
In ischemic cardiomyopathy in patients with, really only in patients with coronary disease has it ever been proven.
Yeah, you may have
talked about this because I came in late, but, can you speak to people who want to get pregnant again after this?
Yeah, so in general, the big deciding decision factor is whether or not their ejection fraction has recovered. If their ejection fraction has recovered, then it's at least reasonable to consider. But the things that we would tell them going in are you have an increased risk of your LV function worsening again. You have an increased risk of your LV function staying depressed even after the second pregnancy, even if it recovered the first time. But there doesn't seem to be an increased risk of mortality. And one of the things that I didn't include for the sake of time is in some people there are some data in using stress testing, so the Vitamine echo, to assess contractile reserve in patients with recovered function. And if their contractile reserve is normal, so they have a normal response to dobutamine stress testing, then that generally portends, at least again in some small studies, a good overall prognosis in terms of reduced morbidity during the pregnancy. In patients whose EF has not recovered, it's generally discouraged, and there is a significant increased risk of mortality in this patient.
Yeah, I think unfortunately we have patients who will get pregnant anyway.
Yeah.
And that's the hard part.
Right.
Is when they come back despite recommendations.
Sure. And I think again that's potentially where the role of aggressive medical therapy up front, potentially including bromocriptine or some of the other novel drugs, and frequent serial echoes would be in order. And again, in those patients, that's someone that I would do probably at least one echo per trimester, and certainly with any change in clinical status would be someone you would want to follow very closely.
So we also have significant hypertensive population, and sometimes they present with acute hypertension, very severe, and preeclampsia, severe preeclampsia, and then they also have heart failure.
Right.
And they have low ejection fraction. So how are you classifying these patients?
And that's I think somewhat difficult to answer, because a lot of the early studies that were done in peripartum cardiomyopathy excluded patients with hypertension. But at the same time, we know from looking at the data that hypertension and preeclampsia during pregnancy is a risk factor for developing peripartum cardiomyopathy. So I think that's definitely still a gray area. At this point, probably what I would recommend is treating them as if, with medical therapy for their heart failure, certainly, and trying to get their blood pressure under control. I don't know that I would necessarily, if there's a question about the diagnosis, consider early novel therapy with bromocriptine or something like that, and I wouldn't necessarily, if there's a question about the diagnosis, start anticoagulation. But in terms of standard treatment for heart failure, certainly anyone with LV systolic dysfunction should be on that, regardless of the mechanism. And trying to get their risk factors under control would be appropriate. And then I think it's one of those things that we just have to follow closely and assess over time. And if it looks like their EF recovers shortly after pregnancy, then it's typically not a hypertensive cardiomyopathy. Typically, that would be more typical of a peripartum cardiomyopathy. If their EF stays down, then we would treat them, as we would any other patient with persistent low EF.
What do you recommend then for sort of the acute, severe range blood pressure in these patients? Because we kind of ran into this situation the other day that the patient wasn't responding quickly to these longer term medicines,
right.
That they take a little bit of time.
Yeah, so IV hydralazine actually is a very reasonable option in these patients, and typically will get the blood pressure down fairly quickly. We would discourage immediate release nifedipine or things like that as a treatment for these patients in most cases. because they can have some adverse hemodynamic effects in heart failure. Beta blockers would not be unreasonable if they're not acutely decompensated. So even something like labetalol or other things you would typically use for blood pressure, as long as their volume status is okay and they're not in pulmonary edema, they're not acutely volume overloaded, then beta blockers are reasonable. It's really only in the patients that are acutely decompensated that you want to shy away from beta blockers.
And then the hydrolysis, would you consider drip or just repetitive dosing?
I would probably, I've never given it as a drip before. You can certainly give it frequent dosing. Every hour or two if necessary until you achieve the blood pressure goal. Yeah, no, and I mean that's perfectly reasonable. But I would have to check with the pharmacy on the appropriate dosing for hydrelazine drip because I've honestly never used it that way.
And we usually have to tell pharmacy what to do, because they've never done it either.
Yeah.
Any ICU.
Right. Yeah, no, and it's one of those things that typically in non-pregnant women in hypertensive crisis, we would typically use multiple medications, rather than just maxing out on one drug. We fairly quickly use a second medication with a different mechanism of action.
Well, thanks so much.
Yeah, thank you very much.
Thank you.